And the right ventricle is the most anteriorly situated cardiac chamber over the four chambers of cardiac chamber. It is by MRI image. It is located anterior positioned, and it is located inferior border of the cardiac silhouette. It consists of the right cardiac border is like here. And the right ventricle is consists of three portions. It is known as inlet, which means from tricuspid annulus inlet point, and apex. It is usually heavily trabeculated, but it is very thin at the RV apex as 1.5 millimeter, and it is consists of the outflow tract outlet, which is consists of below the pulmonary valve. And the RV is the more familiar of two ventricle chamber because it is very easily accessed by a transvenous approach. It is the fluoroscopic view of the heart. It is AP, RAO, and LAO, and this is the model of the chamber at each angle, and the AP shows us some RV, PA, LV, RA, aorta, and during the RAO chamber, it is the RV, LV, RA, and aorta pulmonary artery. So by drawing this line, it can divide the atrium and ventricle like this. And during LAO, you can see the chamber, but at the parasagittal, the septal line is drawn like this. It's so RV and LV. Right ventricular outflow tract is the anatomical border is the pulmonary valve superiorly, and the upper loop of tricuspid annulus inferiorly, and the septum and pre-wall is consisted. So, but actually, RVOT septum is not the true septum because it does not contact with the left ventricle. And RVOT passes superiorly and leftward and separated over the LV outflow tract like this. So it is crossover relationship between the RVOT and the RVOT tract. And the RVOT between the septum and pre-wall, look at this. This is the pulmonary valve, out valve, and this is the septal side and the pre-wall side. You can see the out valve and the out coronary sinus, right coronary out, left coronary is very close to the septal side of RV outflow tract. Look at this. Posterior septal side is very close to left anterior descending artery, and the anterior septal portion is very close to right coronary artery. So we should be very cautious when we some ablation at that site to avoid the coronary artery injury. And the musculature of subpulmonary infundibulum its thickness is 1 to 2 millimeter distally. It tapers when it crosses the distally at the junction of the pulmonary valve and the myocardium. It's a musculature in the subendocardium looks like this. And by microscopic findings at the subpulmonary infundibulum, pulmonary valve, and the myocardial fiber orientation is longitudinally at the epicardial area, and the subendocardial area it is circular along the pulmonary valve, and sometimes it is, some endocardial fibrosis area is can be found when the microscopic finding, and some I think it may be the cause of the some arrhythmia focus along that area. So RVOT protein is very important because it is the most common idiopathic VT focus, and it's manifested as a frequent VPC, non-sustained repetitive ventricular tachycardia, and sometimes paroxysmal sustained ventricular tachycardia. RVOT VT has a more female predominance. Its mechanism is caused by calcium-dependent triggered activity or focal activity. It shows benign prognosis, but sometimes it is not so benign because my case of some patient with syncope, he showed us some PVC from the RVOT, but it degenerated to the polymorphic VT many times, and it can be ablated at the pulmonary artery above the pulmonary valve. So after that, he have no VPC. So mapping of RVOT VT is very challenging. So you can we can find the focus of arrhythmia by ECG, pace map, or activation map. ECG showed some typical finding of RVOT ventricular tachycardia. The 1, 2, 3, and precordial lead. It showed the LVVV morphology, and sometimes 2, 3 AVP was positive. So some difference between RVOT septum and the RVOT pre-wall RVOT pre-wall has some notch in the QRS and some more wider QRS complex. So it is the diagram of the RVOT VT localization by ECG criteria. Those some anterior septal, posterior septal, posterior pre-wall, anterior pre-wall. Anterior portion has a more negative at lead 1, and the ABL was more prominent. And the caudal portion has a ABL was positive rather than cranial portion as the ABL was negative axis. And the pre-wall origin has a more wide QRS complex and notched R wave in the inferior lead. So by it is the two ablation of the RVOT VT. There is I'd like to show two mapping technique. It is one of the mapping technique is using the inside balloon catheter, which use the balloon multiple electrode at the RVOT area. It can catch the arterial activation sequence at the same time at the many at many sites. It is a kind of the RVOT mapping, and when VPC was occurred, it can show where is the earliest activation site of the RVOT area. So by ablation at that area, we can remove the arrhythmia from the RVOT area. I'd like to show another technique to have some more simple method. We use the circular mapping catheter like this at the RVOT area, and we can check the simultaneously 10 electrodes at the same time during VPC. So when we check the QRS onset from at this area, we showed some more earliest activation at this area. So we target at that area, so we can remove the arrhythmia. So we compared some RVOT VT ablation according to mapping technique, inside multiple electrode array and adjustable lasso catheter. 86 patients was compared, and it showed some recurrence rate and procedure complication is comparable. And with the lasso catheter, procedure time and fluoroscopy time is significantly decreased. So I think to map the RVOT area, some circular mapping catheter is very useful. So we want to know the dimension of the RVOT area for the patient. We measure the patient RVOT dimension at the RVOT area, pulmonary valve area, and the pulmonary valve sinus area at each area by the aerial view and the aerial view. This patient shows some aerial view. Pulmonary RVOT dimension was 16 millimeter and 14 millimeter at each view. But another patient shows some more dilated RVOT area. These patients show markedly dilated RVOT dimension, which measures at just 47 millimeter, and by aerial view, 31 millimeter. So when we measure the RVOT dimension at the aerial view and the aerial view, its mean value was 29, about 30 millimeter, and 26 millimeter by RAO, and its maximum and minimum value was variable. So Clinical result of RVOT VT ablation by last is comparable to 3D non-contact mapping system, and it decreased the procedure time and the fluoroscopic time. And the pulmonary infundibulum is a tubular muscular structure, and its length, size, angle is variable, and the size of infundibulum is independent of the general size of the RV. So now we are developing some new circular mapping caster is necessary for RVOT mapping, because the previous last caster was originally intended to map the pulmonary veins. So I think we are now developing this new circular mapping caster. I'd like to present some RV for the RV pacing as regard to RV pacing. RV apex has been standard pacing site. However, deleterious effect of RV apical pacing have increasingly been documented, which is related to abnormal electrical and mechanical activation pattern of the ventricle or ventricular dysynchrony. So by RV apical pacing caused the dysynchronic ventricular motion, so it makes worse in heart failure, more developed atrial fibrillation, mitral regurgitation, and mortality and morbidity. Sometimes it is easy to develop tamponade because the RV apex is very thin in some patients, and this cardiac stimulation of some extra cardiac structure, such as phrenic or intercostal stimulation. So it is time to change the optimal pacing site. So some changes are challenging is the pacing site is the optimal pacing site is the shorter the distance from the impulse to travel to reach the Purkinje system, it makes the more effective contraction. So from the RV apex, we moved some RV septum to RV pacing. It may be more effective and more physiologic. So I'd like to show some case of RV outflow tract pacing. This pacing, RV pacing lead tip is around here, and it shows the axis of the superior axis, inferior axis positive, and the axis deviation is not so, and the QRS duration is about 133 milliseconds. It is narrower than the RV apical pacing. So another case of the RV lower septal, mid septal pacing, pacing site is around here, and it causes a more narrower QRS duration. QRS duration more 112 milliseconds. I believe it is more physiologic pacing rather than RV apical pacing. So, but there is some concern about where is the optimal site by anatomical base. The proposed target zone for pacing purpose is the septo-parietal trabeculation in the inferior portion of the septal RVOT, or septo-marginal trabeculation, which are located at this figure, septo-parietal trabeculation in inferior portion or septo-marginal trabeculation. So it is the ideal pacing site target. So to achieve this one, we use this is a case RAO view, AP view, and area view. Pacing site is septal, and RVOT area is the middle of the cardiac silhouette, and some is anterior over the cardiac silhouette by RAO view. So to achieve this pacing site, it is proposed to make some cardiac stylet using the posterior angulation. So to get this septal area, we used some two different angle stylet to get this area. But I have presented about the feasibility of RV septal pacing, as it has a pacing threshold. Intrinsic value impedance was very comparable, and at initial and 3 months follow-up, and the complication related to ventricular lead is comparable by this RV apex and RV septal pacing. 2 cases of dislodgement and 1 case of perforation by RV apical pacing. But although the ideal pacing site is around here, at the middle of the septum, but many of cases, the pacing was really, pacemaker lead was around here because it is very stable at this position, but we cannot recognize that by the fluoroscopy or ECG findings, so it is some limitation of this technique. So there is some steerable sheath for septal pacing is now developed, but it is not commercially used. So non-RV apical pacing is mentioned at the European guideline, and the complication rate of non-RV apical pacing is similar to that of RV apical pacing. But so far, there is little evidence of any long-term benefit derived from this new technique. So task force team did not recommend it until now, but it requires more larger trial to become available. This is my conclusion. Right ventricle is most common site of idiopathic ventricular tachycardia and the primary pacing site. And the detailed knowledge of RV anatomy is essential for ablation and pacing therapy for electrophysiologists. Thank you.